Hello everyone. So continuing with the lecture of anticoagulants, now we'll be discussing about the direct oral anticoagulants. I hope you have seen already the lectures of antiplatelets, parenteral anticoagulants, and the first part of oral anticoagulant, that is on warfarin. Now we'll see about the direct oral anticoagulants. Now first of all we should understand what is the need of direct oral anticoagulants. Now direct oral anticoagulants, it includes either direct thrombin inhibitor or factor 10A inhibitor. Okay, so we have dabigatran, which is a direct thrombin inhibitor, DTI, or we have rivaroxaban, edoxaban, and apixaban. These are factor 10A inhibitors. These drugs, unlike warfarin, they have a rapid onset of action. Rapid onset of action. They are given either OD or BD dose because most of the almost all these drugs they have a half life of around 12 to 14 hours. So they are given as OD or BD doses. They have a predictable response. Predictable response. That's why we don't do monitoring. So monitoring is not required. Monitoring is not required because they have a predictable response and they have a high therapeutic index also. Fixed doses are given because they have a predictable response. Fixed doses are given, and routine monitoring is not required. Routine monitoring is not required. So these are the advantages of direct oral anticoagulants over warfarin. So that's why we are now changing on to many of the cases we are now starting with direct oral anticoagulants instead of warfarin. Now coming to the indications based on the studies. Now all the four drugs, that means the dabigatran, rivaroxaban, apixaban, and edoxaban, all of them, they are licensed for stroke prevention in non-valvular AF cases. Non-valvular AF cases. That means it doesn't include patients with mechanical heart valves or patients with rheumatic heart disease. Rheumatic heart disease related AF is not included. So non-valvular AF in these cases for stroke prevention it is licensed, and also for treatment of venous thromboembolism. Dabigatran, rivaroxaban, and apixaban, all of them are licensed for thromboprophylaxis after elective hip or knee replacement. For this indication, edoxaban is only licensed in Japan for this indication. Otherwise, dabigatran, rivaroxaban, and apixaban are licensed everywhere. Finally, the low dose rivaroxaban. It is licensed for use along with aspirin. For secondary prevention in patients with coronary artery disease or peripheral arterial disease. Okay, so these are all the indications. The most important indications are stroke prevention and treatment of venous thromboembolism. But low dose rivaroxaban alone is approved along with aspirin as secondary prevention in patients with coronary artery disease or peripheral arterial disease. Now coming to some of the characteristics of all these drugs. Target I told, rivaroxaban, it is 10A inhibitor. Rivaroxaban, apixaban, and edoxaban, they are 10A inhibitors. Dabigatran is thrombin inhibitor, that is factor 2 inhibitor. Rivaroxaban is not a prodrug. The factor 10A inhibitors are not prodrugs, but dabigatran is a prodrug, that you have to remember. Bioavailability, you have to remember 80, 60, 50, and 6 percentages. So maximum bioavailability is for rivaroxaban, followed by apixaban, edoxaban, and dabigatran. Dosing for rivaroxaban, it is either OD or BD dosing. For apixaban, it is BD dosing. For edoxaban, it is OD dosing. For dabigatran, it is either OD or BD. Half-life for all of them around 12 hours. For all of them around 12 hours. Around 12 hours. Slightly higher for dabigatran, that is 12 to 17 hours. Renal excretion is there for all of them. That is around 33% for rivaroxaban, 25, 35, and 80. So maximum for dabigatran. Interaction: the first two drugs, rivaroxaban and apixaban, they will interact with drugs that modify CYP3A4 enzyme, or those drugs which will modify the P-glycoprotein. P-glycoprotein is a efflux pump. For apixaban also same. The drugs that modify the CYP3A4 enzyme or P-glycoprotein, they will affect the function of rivaroxaban and apixaban. For edoxaban and dabigatran, it is only the P-glycoprotein inhibitors that will affect edoxaban and dabigatran. It will interact with these two drugs. So P-glycoprotein inhibitors are usually verapamil or quinidine. There are so many other drugs, but these are important names. Now coming to this table, here you can see this table is showing the different doses that are used for different purpose. This one is most important. Exact doses are not important if you are not practicing. If you are not resident, then it's not important. But the important points that you should remember from this table that I need to tell is, first point is rivaroxaban. This is given along with meal. This is given with food that will increase the absorption. Dabigatran is also preferred to be given along with food because that will reduce the dyspepsia that is associated with dabigatran. Apixaban and edoxaban, they can be given with food or without food. Okay, this is the first point to be remembered. Okay, second point is for which drugs you need bridging and for which drug you do not need bridging. So bridging is recommended only for dabigatran and edoxaban. I hope you all are aware of the bridging concept that we have already discussed in the heparin and warfarin section. So bridging is required for dabigatran and edoxaban and not required for apixaban and rivaroxaban. These drugs can be started directly. Okay, so this is the second point. The next point is the dosing modifications that are required in presence of renal failure. Remember for dabigatran, if the creatinine clearance is between 15 to 30, then the dose 150 dose has to be changed to 75 mg. For apixaban, I have mentioned here, it's an important point given in Harrison. Apixaban is given at 5 mg BD mostly, but dose has to be reduced to 2.5 mg BD for patients who have at least 2 of the ABC criteria. So what is this ABC criteria? Age more than 80 years, body weight less than 60 kg, or creatinine is more than 1.5 gram per deciliter. So if any of these three is there, any 2 of these 3 is there, then you have to reduce the dose of apixaban. For edoxaban, if creatinine clearance is 50 to 49, then you have to reduce the dose to 30 mg. For rivaroxaban, if the creatinine clearance is 15 to 49, then you have to reduce the dose to 15 mg. These are some of the modifications that you have to do along with the creatinine clearance. Okay. I told most important one is, if you want to remember the dosing, you can remember for VTE treatment. For dabigatran, you have to do bridging. So you have to start with parenteral anticoagulation. Along with that, you have to start with dabigatran 150 BD. Apixaban or Eliquis, it is 10 mg BD for 1 week and then 5 mg BD. If the renal function is normal, if not, then I have told how to modify the dose. 2.5 mg BD you have to give. For edoxaban, you need bridging, so parenteral anticoagulation, then 60 mg OD for rivaroxaban. Rivaroxaban 15 mg PD for 3 weeks, and I told it has to be given with food. Then 20 mg OD with food, and I told dabigatran also has to be given with food to reduce the dyspepsia. Apixaban and rituximab you can give with food or without food also can be given. Now coming to monitoring, in the beginning I told the patients who are taking these direct oral anticoagulants, they do not need routine monitoring. But for the academic purpose, we can remember that the drugs, the factor 10A inhibitors, factor 10A, if the patient is taking factor 10A inhibitors, qualitative monitoring can be done using the prothrombin time, and patients who are taking dabigatran, APTT can be used. But if you want more selective monitoring, then for patients taking factor 10A inhibitors, we can do factor 10A assay. And for patients who are on dabigatran, we can do chromogenic. You can do diluted thrombin clotting time, or one more is there, that is heparin clot time. This factor 10A assay is chromogenic assay. So chromogenic factor 10A assay, or for dabigatran you can do heparin clot time or diluted thrombin clotting time. However, in clinical practice these things are not done. Now coming to side effect and procedural management. Side effect, the most important side effect, as you all know, it is bleeding. One important point is the patients who are on direct oral anticoagulants, they have less risk of IC bleed compared to warfarin. However, there is more risk of GI bleed. How to manage it, I will be telling in the next slide. Then apart from bleeding, I told dabigatran is associated with dyspepsia, and dyspepsia is seen in 10% of patients with dabigatran. And I told if you give with food, give the drug with food, then dyspepsia will reduce. Then regarding the procedural management, I told in cases of warfarin, if the patient is on warfarin and if the patient is low risk, you don't need to stop warfarin. Similarly, even for direct oral anticoagulants, if the patient is low risk, that means the procedure is low risk, then no need to stop the drug. However, if there is moderate to high risk procedure, then you have to withhold the drug, and the drug has to be withheld before 1 to 2 days. For warfarin it is 5 days, and for DOAC it is 1 to 2 days, or maybe longer if the patient has renal failure. Renal failure. Now coming to the management principles of DOAC toxicity. Again, any patients with bleeding, we have to withhold DOAC. That is the first step. Withhold DOAC. If within 4 hours, you can give a trial of activated charcoal. Then, in most of the hospitals, we do not have proper antidote for these newer drugs. So most of these patients, we have to provide supportive therapy with FFP or 4-factor concentrate or prothrombin complex concentrate. Then you can also give antifibrinolytic agents, tranexamic acid, and antifibrinolytic agents. For dabigatran, you can do hemodialysis also. Hemodialysis can be given for dabigatran. Then if you want to know about the antidotes for dabigatran, it is idarucizumab. For factor 10A inhibitors, it is andexanet alpha or serapantag. So these are the 2 drugs for factor 10A inhibitors. However, they are not available in most of the centers. Okay, so this is how you manage the DOAC Toxicity. Remember, DOACs has to be avoided. Avoid in pregnancy or lactation. I told warfarin should be avoided in pregnancy. You can give in lactation during lactation period, but DOACs has to be avoided. They have to be avoided during pregnancy and lactation both. Now this is the table from Harrison where they have mentioned about anticoagulation in venous thromboembolism, how to do non-warfarin anticoagulation and how to do warfarin anticoagulation. I have already discussed all these things. This is a summary. Just you can just after seeing all these lectures, you can just go through this table once. And here for prevention of VT, that is prophylaxis. Okay, so this also you can read once after seeing all the three videos. So with that we are ending with the anticoagulants, and in the last part we will be discussing about the fibrinolytic agents.